The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Workus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. Welcome back to the Virtual Curbside. This is our monthly episode 4, where we get to ask our speaker all the questions that we've gotten from our episodes for the month so far. And by the way, thanks for all your questions and feedback. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the Virtual Curbside. It's always nice when we have a chance to come back with a guest and deal with some questions that may have lingered after we talked. We're very fortunate to have Dr. Rajiv Iyer with us again today. Welcome back.
Thank you so much for having me back.
Heard nice things, and so I'm looking forward to being able to revisit a couple of things with you.
Likewise, thank you.
All right, well, let's dive right in. First question. What's the role for anti-inflammatories and physical therapy in the treatment of tethered cord? How much do they help, and should we feel any caution about using them?
I see no caution in using physical therapy or anti-inflammatories in tethered spinal cord, but just to keep in mind that sometimes anti-inflammatories involve NSAIDs, and many of our spina bifida patients may have some renal issues. So I think that's the one thing to have some caution about. Generally speaking, I consider tethered cord, especially as it relates to myelomeningocele, consider it to not be a very progressive process. So when we see progression of symptoms with myelomeningocele patients, it really raises red flags about tethered cord. And unfortunately, I don't think there's great evidence that suggests anti-inflammatories or physical therapy would halt that process. There's tension on the spinal cord. More activity could lead to worsening symptoms, but pain management with anti-inflammatories is certainly an option. Also, neuropathic pain medicines have been tried in the past, like gabapentin. Also, things like Botox injections with tone-related issues. But generally speaking, I haven't personally found these interventions to be extremely helpful, except for perhaps some mild cases. And like I said, when you have progression of disease, generally neurosurgery is sort of the route where that's going to end up helping these patients the most, I believe.
Terrific. Next question. What can you tell us about syringomyelia? How does it present? What's the natural history? It seems that I should be more familiar with it maybe than I have been in thinking about causes of tethered cord.
Sure. Whenever I see a syrinx in the spinal cord or syringomyelia, that's basically the accumulation of fluid within the center of the spinal cord. And believe it or not, many patients who have severe syrinxes can have minimal symptomatology. It's quite unbelievable. I recently treated a patient with a spinal cord tumor who was running around and playing soccer, and the symptom that they had with a large intramedullary spinal cord tumor and holocord syrinx that extended up and down their spinal cord was an atypical scoliosis, believe it or not, with minimal neurological symptomatology. So there could be a significant discrepancy between symptomatology and the syrinx itself. But why does the syrinx develop? It's a great question. We have some understanding of that. It's not perfect. But for example, take a patient with a Chiari malformation or tethered spinal cord, CSF pulsations in the setting of a Chiari malformation. You can have pistoning of the cerebellar tonsils, which can lead to the development of fluid within the spinal cord. That's one theory. And with tethered spinal cord, it's a little more complicated. I don't think we have a great understanding, but undue tension on the spinal cord can lead to radial stress and tension on the spinal cord, which can be more of a capacitor for fluid buildup within the spinal cord. Obviously, compressive issues, if there's a lipoma or something pushing on the spinal cord, can lead to fluid buildup within the cord itself. The natural history, really, I consider that with respect to what's causing the syrinx. Anytime I see a syrinx, I'm looking for the cause. Sometimes we never find the cause, and that's what we in a field call idiopathic syrinx. But if we see a syrinx, we look for other things related to the spinal cord, like a Chiari malformation, tethered spinal cord, an intramedullary spinal cord tumor, a history of an injury, such as a trauma to the spinal cord itself, a previous infection. In the absence of those things, then we're usually calling that an idiopathic syrinx, and usually those don't cause problems, usually don't grow. We may get one more image with contrast to make sure there's nothing growing in the spinal cord, but usually those do not cause problems to our patients.
And can a patient have an idiopathic asymptomatic syrinx their whole life and we don't know about it?
Absolutely. And so with the advent of MRI and our screening for patients with back pain or scoliosis, there's probably an increased detection of idiopathic syrinxes, but we generally think that these patients are going to be okay.
Yeah. It doesn't exactly do my heart good when you talk about a patient with a serious condition and mild symptoms. That strikes terror in the heart, I think, of the average pediatrician because we worry about who to be more worried about.
I totally agree. And especially as it relates to scoliosis, we've done a great job, I think, as a field, orthopedic surgeons and neurosurgeons in terms of, and pediatricians, detecting atypical patterns of spinal curvature, hyperkyphosis, a leftward curvature, believe it or not, the male sex, all of these things, may lead to, or abnormal reflexes or asymmetric reflexes have led to an increased use of MRI, which can help detect a secondary cause of a scoliosis, which can involve a syrinx.
Very helpful. Here's an interesting question, or at least it is to me. Is there a relationship between pilonidal cysts and tracts and spinal cord anomalies and spina bifida?
I think my answer will be short. I don't think so.
Okay.
I've not personally seen that before. I've not really read any reports of that. It's not well known if it is. Maybe there's a case report or two out there, I'm sure, but I don't think there's a relationship.
Different developmental issue.
Different issue. Yeah,
Okay.
exactly.
Okay.
Exactly.
Great. All right. Well, revisiting something that I'm sure you revisit all the time. How definitive is an ultrasound of a pathologic sacral dimple? And would you mind reviewing again the characteristics of a benign sacral dimple?
Sure, absolutely. So, a sacral dimple, I differentiate from a coccygeal pit. The sacral dimple is above the gluteal crease, and ultrasound is a useful screening test. So we often see it. Often pediatricians will pick it up and, see that in the lower back of an infant, get a screening ultrasound, which has a certain level of sensitivity. The reports vary, to be honest with you, anywhere between maybe 80 and 95%. I do think it's a useful screening test. I do believe it to be a fairly sensitive test. I'm not, and I think pediatric neurosurgeons as a group, I don't think are generally ordering this as a study. Once we see a patient, if there's concern enough, we'll usually just resort to getting an MRI of the lumbosacral spine. And that's obviously far more sensitive and specific in terms of telling us what's going on. Is the conus at a low level? Is it in a normal position? Is there a fatty phylum present? So I do think ultrasound is a useful screening modality for a sacral dimple in terms of identifying tethered spinal cord. And dimples within the gluteal crease, those are ones that, especially if they're epithelialized at their base in a neurologically intact patient, are the ones that I generally consider to be benign.
Sometimes in the description of sacral dimples, one of the discriminators that's listed is the distance from the anus. I think it's like 2.5 centimeters or something. Is that useful?
Not necessarily the measurement itself. I never used that specific measurement, but it brings up a good point in that if there's a sort of pit present within the gluteal crease of an infant, then understanding whether the base of that pit is epithelialized or not. And number two is oftentimes you can palpate that dimple or pit. And if you palpate the tip of the coccyx or the tailbone, we generally think that that is less concerning of a finding and more benign. So I think that probably owes to what you're saying in terms of its proximity to the anus.
Because it feels a little arbitrary. So I think what you're saying is very, very helpful, that looking at the nature of this as well as the location is important.
Exactly. And especially, taking into consideration whether there's been any drainage from such a finding on an infant, whether it's midline, whether there's a symmetric gluteal crease, all of these things matter. And obviously, looking for other cutaneous manifestations of occult spinal dysraphism, such as hypertrichosis on the skin, or any red spot or hemangioma, or growth, or sort of asymmetry, any fat you might see that's sort of abnormal appearing. All of these things certainly raise the suspicion for occult spinal dysraphism and warrant further investigation.
Very helpful. Let me ask you another question. I didn't put this on your list. I want you to clarify for us again some of the advantages that happen when people are able to be cared for in a multidisciplinary clinic like you have. What sorts of things then are helpful to you, helpful to me, and helpful to the patient about that?
Absolutely. And I believe you're referring to our multidisciplinary spina bifida clinic.
Right.
I think it's extremely useful because we consider spina bifida or myelomeningocele specifically to be a chronic disorder. So as children grow, it's very beneficial to have access to multiple specialties that may sort of come and go in terms of the relevance in terms of that patient. For example, neurosurgeons are extremely relevant really early in the life of a spina bifida patient, especially open spina bifida, but perhaps become, I hate to say it, but a little bit less useful in the earlier phases of after closure, right? Except for whether we're dealing with hydrocephalus. And then other things become more relevant, such as orthopedic manifestations, the use of braces, physical therapists, urologists who can monitor kidney function over time and tell us whether renal health is okay and bladder health and detect subtle changes over time with urodynamic testing and bladder testing and manometry. And so we all kind of ebb and flow in terms of the care of a spina bifida patient over time, especially as it relates to their growth and whether tethered cord manifests, things like that. So I think having a central location where we can monitor that over time is extremely useful. And it's almost like one-stop shopping for families who can come in and see the providers they need to see and make sure we're keeping track of things over time. I think it's also beneficial from a provider standpoint because we can help inform the world and pool resources and pool our data and help to better understand these disease processes. And to have it be more centralized, protocolized is extremely useful in doing so, especially as it relates to things like the National Spina Bifida Patient Registry and other more focused studies that we can do to help with outcomes in our patients.
As I was reflecting on it, I was thinking in a lot of ways this benefits somebody who lives closer to a center, but I think in a lot of ways it benefits somebody who lives more distant from a center because you can have that, as you say, one-stop shopping to try to coordinate your care.
I absolutely agree with you. It must provide so much relief to both patient, family, and provider, to be honest with you, to see these patients on a regular basis if they live far away, to be able to come in every year and just check in with everybody, make sure we're doing okay from a tethered cord standpoint, from an optimization standpoint, and to have a central hub and sort of a hotline, right? That this can be your resource to call in, and even if you live many, many miles away, to know that resource exists, at least to help triage a scenario.
Right. And clearly, one of the points that you made over the month is that there are a lot of these issues that we don't do on a regular basis. And one of the great advantages we have is we can call you or someone like you and talk through these things.
Absolutely.
I think sometimes we feel like, going to the ultrasound question a bit ago, that we feel like we need to try to answer the question. I think what we're trying to do frequently in primary care is just to formulate the right question to be able to have you guide us through.
Absolutely. And our phone lines are always open. So if there's any questions or concerns, then we're concerned and we want to know about that. So greatly appreciate all those who are in the trenches on the front lines and seeing these things to help detect. I think that's the most important thing, is to be able to detect, ask the right question, and send to the appropriate subspecialist if needed.
And if somebody wanted to reach you, how would they do that?
So our phone number for the pediatric neurosurgery office here at Primary Children's Hospital is 801-662-5340. And if there are ever any questions, I'll provide my email address as well. Please feel free to reach out anytime. My name is Rajiv, RAJIV.IYER @hsc.utah.edu.
Perfect. And my spina bifida trivia for the month, as I was doing some reading, I guess I had not realized that John Mellencamp had spina bifida and was the beneficiary of unusually aggressive surgery as an infant, and that made all the difference for him.
Wow, I didn't realize that.
Well, that's what I'm there for. I don't have much knowledge, but I have plenty of trivia. So thanks for your time and expertise, Rajiv. This has been very, very helpful, and look forward to talking to you again sometime.
Absolutely. Thank you so much for having me. It's been a great pleasure.
Thanks so much. Thanks for joining us. We look forward to getting together again next time. The virtual curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Production design and editing thanks to Phil Workus, who also composed the theme music. See you next time.